Good morning, good afternoon, and good evening, and welcome everyone to today's webinar on maternal, newborn, and reproductive health in emergencies and COVID-19, successes, challenges, and next steps. This webinar is developed in collaboration between IAWG and the READY initiative, a Save the Children-led consortium augmenting global capacity to respond to major disease outbreaks. My name is Ryan Toney, Learning and Development Specialist with Save the Children and READY, and I'm pleased to be your host today. So welcome everyone, and thanks so much for joining. Today's session will be broken up into two parts. So first, we'll be hearing a presentation from Alice Janvrin. Alice is an independent consultant who recently conducted a series of discussion-based expert consultations, reviewing MNRH in the preparedness and outbreak response context to identify specific priorities for this ongoing COVID-19 pandemic. Her presentation will present some of the key findings and recommendations from this consultation series, which can also be found in the report, which we'll share in the chat box in just a moment. And then after Alice's presentation, we'll transition into a panel discussion and an audience question and answer, where we'll get a chance to pose a few questions to our panel today. We're lucky to be joined by Ashley Wolfington. Ashley is a global health consultant with 15 years of experience in public health and communications and expertise in sexual and reproductive health. We're joined by Shehu Dasagit, Regional Public Health Specialist for IRC in Sierra Leone, who's been involved in clinical and public health responses for the last decade. And last, but of course not least, we're joined by Donatella Masai. Donatella is the lead technical advisor for the READY initiative, who's been involved in emergency health response programs for the past 20 years. So we're really grateful to have her expertise on the call today. If you have any questions during this presentation or for our panelists during the Q&A period, we do encourage you to make use of the chat box or the Q&A feature at the bottom of the Zoom screen. We will have some dedicated time to answering audience questions at the end of the Q&A. And then please also note that a recording of today's session will be made available to all participants via email, and will also be made publicly available on READY's website after the webinar. With that, I'm now pleased to welcome Alice to begin the presentation. Thanks, Alice.
Great. Thanks, Ryan. Hello, everyone. It's great to be with you today. I'm just going to wait for Ryan to put the slides up and we'll get started. Wonderful. Great. So my name is Alice Janvrin. I have been working on this expert consultation with my colleague Gillian McKay. Gillian had a baby a few weeks ago, so she can't be with us today, but important to be acknowledged in this process. So today I will talk you through the process and the findings of this consultations on maternal, newborn, and reproductive health in emergencies and COVID-19. Slide. So as I'm sure you're aware by now, COVID-19 pandemic spread across the world in this 2020 year and caught the humanitarian community largely unprepared to respond. MNRH, maternal, newborn, reproductive health, priorities were not often included in preparedness plans and were often an afterthought in the COVID-19 response. Experiences and lessons learned were compiled to identify the challenges and gaps in implementing humanitarian MNRH services in COVID-19 across the world. Slide. So our methodology for this consultation, we ran 4 workshops. One was in French with a group of Francophone participants, and 3 were in English and covered preparedness, response, and recovery of the COVID-19 outbreak. Each session was split into 3 breakout groups, with one group discussing maternal health, one group discussing newborn health, and one group discussing reproductive health. The participants were purposefully selected to ensure a diversified group. So we invited 68 participants, 60% were global level and 40% were national level, with representation from NGOs, UN, research institutions, donor institutions, ministries of health, independent consultants, and we had an average of 30 participants a day, with a few participants coming for several days in a row. We took notes on all the discussions that were had during these workshops, and the notes formed the basis of the report and of the presentation I'm giving you today. Slide. So looking at the findings, we explored the adaptations that were made and the successes and challenges, and we structured this around the 6 pillars of the health system. So the first pillar, the health workforce, we found that routine MNRH, as well as COVID-19 specific trainings and supervision had to go remote and online. And this caused a lot of logistical challenges for contexts with bad internet connections or environments where there weren't enough computers, etc. We found that midwives were often overlooked from trainings, and particularly COVID-19 related trainings around infection prevention and control, IPC, PPE, that sort of thing, even though they are best placed to understand the needs for maternity wards. We've seen this discussed in many different spheres, but we frontline workers have been faced with unsustainable levels of stress, with increased workload, fear of perceived as well as real infection, and stigma associated with their work. We also found that community level providers, by this I mean community health workers, traditional birth attendants, were often excluded from the adaptations that were done to health services in face of COVID-19. The second health pillar, service delivery, adaptations programs had to be adapted to respond to COVID-19. These adaptations included restructuring service layout, low or no touch services, services with smaller patient groups, for example, for antenatal care, providing commodities such as family planning commodities for longer period, and where feasible, telephone follow-ups such as for postnatal care. MNRH was not prioritized in COVID-19 response guidelines, at least initially in the response. And we found that efforts to improve service demand through creating better, stronger community networks and paying more attention to their feedback, such as through RCCE, risk communication, and community engagement approaches. These approaches have really improved since COVID-19 has started, and should really be capitalized to be used also for the MNRH sector. According to participants, we have heard of a decrease in facility-based MNRH services. So for example, facility-based deliveries. So there is a need to increase community-level MNRH services. Slide. The next pillar is around health information systems. So M&E monitoring and evaluation systems did break down due to COVID-19 prevention measures, such as the movement restrictions and social distancing. So for instance, a district supervisor was less able to access facilities to go and pick up the data from that facility, to go and check the reliability of that data. And some of the adaptations that were made, such as creating online data collection tools, creating online meetings, were not suitable for every context. We also found that MNRH and outbreak response data collection tools need to adapt to each other. By this, I mean that, for example, an MNRH register should include a data point around COVID-19. Conversely, COVID-19 data collection tools should include MNRH related data, for example, whether the patient was pregnant. This would therefore allow us to get a better understanding of the interaction between MNRH and COVID-19, and also better understanding of how COVID-19 is impacting MNRH. The finance pillar of the health system. So as mentioned earlier in the introduction, preparedness plans were not systematically developed. If they were developed, they did not systematically include MNRH as an essential service, and they were not systematically funded. We also saw and heard of resources being diverted away from MNRH services towards the COVID-19 response. However, on the plus side, there are new opportunities to diversify sources of funds for MNRH, new philanthropies, new national donors, etc., that have appeared during this COVID-19 and that could be mobilized and capitalized on to support MNRH moving forward. Slide. So medical commodities, as we've all heard, there's been an unprecedented demand for globally for PPE. This has impacted both international and local markets, and we have heard across the world over stockouts of essential PPE in all services. We've also heard during our workshops that there were a regular diversion of PPE towards areas in hospitals that were perceived with having a higher COVID-19 risk. As a result, MNRH staff were forced to adopt high-risk behaviors, for example, reusing single-use masks, single-use gloves, etc. This increases the risk of COVID-19 and of course affects the quality of MNRH services. There were also stockouts of MNRH commodities because once again, MNRH were not included in preparedness plans. The final pillar of the health system is governance and leadership. And we heard of a lot of coordination issues between the COVID-19 response structure and the sometimes pre-existing to COVID-19, the MNRH response structure. And when these didn't work properly together, it led to contradicting guidelines and created confusion and tensions, particularly at field level. Slide. So next, we looked at the tools and guidance around MNRH in emergencies and COVID-19. So many organizations issued MNRH tools in response to COVID-19. However, WHO and IAWG issued the most commonly used guidelines to operate and adapt MNRH programs during this COVID-19 pandemic. There are a few gaps in the guidelines still, particularly around home-based care and around the management of newborns in COVID-19. And some of these gaps have led organizations to develop their own tools or to rely on guidance that's been developed by national professional bodies or bodies external to the humanitarian sector. There has been an overload of guidance coming in, and there is a necessity to adapt to the ever-changing local contexts. We also have these frontline staff with face-to-face experience with the needs on the ground, and we need to better elevate their experience to be reflected in the guidance. And also to involve them in how this guidance is rolled out. Slide. So we also looked at the dissemination of guidance. So from the point where it's developed to the point where it's being implemented. So mainly global level tools get filtered to the implementation levels through national ministries of health. The ministries of health liaise with WHO, CDC, etc. to pick the best guidance and turn these into policies that they then translate to the local level ministries of health, who usually chair health clusters and RH sub-working groups, and that's how they reach the implementation levels. However, specific MNRH guidance developed by IAWG or INGOs did reach the implementations, but not through the ministries of health, but through member organizations of IAWG or country offices, regional offices of INGOs. And this could create a clash at implementation levels for implementation teams who received separate guidance from local authorities and from internal organization authorities within their own organization. Slide. So we developed a set of recommendations that are split into 4 categories. The first category is around health workforce and service delivery. So we need to invest in the training of MNRH staff in outbreak response. And these need to be, we need to include MNRH staff early on when we prioritize staff to be trained in an outbreak response. We need to figure out approaches to retain healthcare staff. We've trained a huge number of people in how to use PPE and IPC. We mustn't lose that knowledge, and we need to work out approaches to retain these trained staff. We also need to identify the training programs that worked and why did they work, where did they work. We need to do a bit of research on that. We need to invest in workforce well-being, and not just during a response, but always, and especially during preparedness, so as to make sure that the workforce is resilient when a health crisis appears. And we also need to make sure that their experience informs the guidance, so that we have a bottom-up approach as well as a top-down approach. We need to make sure that IPC supplies are included in MNRH kits. And we also need to make sure that MNRH supplies are included in outbreak response procurement plans. Slide. So the next set of recommendations are around community level MNRH services. We need to develop research and guidance to improve community level care. And this needs to include research for safe home birthing and guidance on community distribution and reproductive health commodities. We need to invest, we need to train, and we need to support community level workforce. The traditional birth attendants, the community health workforce, they are the first port of call for many people in communities, particularly in humanitarian contexts, and therefore they need to be included in the training, in the preparedness, the adaptation of services, and also be included in lessons learned exercises that we're starting to do now regarding COVID-19. We also need to capitalize on the new communication approaches and the new communication networks that have been created or strengthened during COVID-19, and to be used towards creating and strengthening MNRH service demand. Next. So then recommendations around guidance and tools. We need to disseminate MNRH tools through national channels so that we don't see that conflict or that clash at implementation levels. And we need to make sure that the tools are translated in appropriate languages. We suggest developing a comprehensive MNRH tool to adapt services to different types of epidemic. And for all the new guidance that exists, we strongly recommend to have a breakdown of new guidance into rapid adaptation tools to enable easy assimilation of new guidelines. And as I said earlier, we need to provide more support to operationalize tools in local contexts so that developing the tool is not the end game. We really get the tools to be used and useful to frontline staff. Slide. Yep. We need to develop preparedness plans that include MNRH as an essential service, and we need to make sure that these preparedness plans are funded. We need to improve the collaboration between MNRH and outbreak setters at all levels, from global to field level. We need to lead gender impact analyses to make sure that MNRH programs reach the most vulnerable women and girls in the communities we want to serve. And we know that outbreaks have an impact way beyond the health sector, impact on economy, on livelihoods, on protection. So we need to advocate for a multi-sectoral outbreak response. We've also created a lot of new stakeholders and allies with this COVID-19 that we need to capitalize on to improve on MNRH services. So by allies, I mean new donors, research institutions, suppliers, private sector, etc. Slide. So a few points on the limitations in this expert consultation process. We structured the workshops around the outbreak phases, so around preparedness, response, and recovery. However, as I said, most contexts were unprepared and did not have much to say around the preparedness phase for COVID-19, and very few contexts were thinking about recovery. Therefore, the bulk of the material we collected really targeted the response phase of the COVID-19 outbreak response. We also structured the discussions around the different services. So the breakout groups were centered around maternal health, newborn health, and reproductive health. These are all on the same continuum of care, and therefore there were very few significant differences between their experiences. And we found that the different breakout sessions came out with very similar conclusions, one from the other. We led the workshops in English and French, and therefore there was an underrepresentation from other regions, particularly Spanish and Arabic speaking regions. The workshops in true COVID-19 form were online, and therefore that might have restricted access to certain participants who didn't access the internet, and did make it difficult for some people who did make the sessions to really get their point across clearly. And finally, while we did have good representation of national and field level staff, most of these were leadership levels, and there was a scarcity of frontline workers. Slide. So in conclusion, most MNRH guidelines for COVID-19 now exist, but we need more support to properly disseminate, properly adapt, and properly operationalize them so that these are useful for the target audience, which is usually frontline workers. We also need to elevate the voice and increase the capacity of these frontline workers so that they are better prepared to respond to this continuing crisis and future crisis. Slide. That's all for me. Thank you so much for listening, and I hand it over back to Ryan.
Thank you so much, Alice. That was a really great presentation. And I do want to remind folks that those findings and more are available in the report that Alice drafted from those consultations, and that's available in the link in the chat box. So what I'd like to do is invite our panelists to rejoin us for this upcoming Q&A period. And while they're doing that, a reminder to please ask your questions of Alice and of the panelists. A few folks have already started doing that, so thank you. You can either use the chat box or the Q&A feature below, and we will have some dedicated time for those coming up in just a few moments. So panelists, welcome back. And my first question is for Donatella, thinking about some of the recommendations that Alice mentioned in the presentation, and as well as reflecting on your experience, I'm wondering if you could share some thoughts about how we could better include MNRH, maternal, newborn, reproductive health, in the preparedness of health responses for future COVID-19 waves, but even for, I think, future outbreaks in general.
Yeah, thank you, Ryan, and thank you, Elise. I have to say that there is somehow little to say that is not included in this report. Really comprehensive. Congratulations to all of us who participate. I found it amazing. And probably this is because you have listened to the voice of many people and you have a bidirectional way of communication. And I think this is the base of future success, to listen the people who are confronted with the issue. I want to introduce my brief response by a citation that I use often, and I was using before COVID was striking all of us somehow by surprise, but not that much. We knew it was coming. We didn't know when. We didn't know the R. We didn't know how it would develop, but we knew. And that is an influenza pandemic could sideline 40% of your workforce, shut down foreign trades, and degrade public services. And this is what basically has happened. We did READY initiative, did a lot of assessment. And I have to say that being a public health expert, and especially focusing big part of my career in outbreak response, I have to say that few organizations are prepared to respond to outbreak. We have seen preparedness plan that includes many of the most common actually issue, like security issue, refugee, mass displacement of population, flood, famine, and so on. But few organizations include health in preparedness, which means that not only MNRH is left over or is forgot or not prioritized, which means that many health services are not prioritized. And I think another thing that is important to say is that I strongly believe that no single organization can prepare for a pandemic on its own. So I think inadequate, and I think Shehu will speak about coordination, inadequate coordination and preparedness as a whole of society, we reduce the ability to respond during pandemic. And this is what we very often do. We go in different zones, we don't coordinate. And especially, I would say that one key, beside having the health in your preparedness plan, it is to do joint assessment. And as Elise has pointed out, to ensure that the right priority are met. And so when you do your assessment, you consider your staff. We have understood that staff, and we have relied so much on national staff and local staff with all the burden in terms of stress and them being sick and not being able to cover the services. We have seen the issue on supplies. We knew that majority of supplies were produced in countries where were hit themselves by the pandemic, so China, India, and we were all taken by surprise, if I can say, knowing that we don't have enough PPE, we don't have enough staff, and the planning as well should be done not only at regional or headquarter level, but it has to go to national, subnational, and finally, and not finally, maybe primarily at community level where these activities are done. I have seen there has been almost a competition among sectors. READY is really pushing all its efforts for a multi-sectoral approach. I don't want to see in my career anymore staff fighting for a mask or for a gown, and then doing delivery just one of the service or antenatal or postnatal care with not enough protection for our staff. So welcome the fact that our preparedness kits or preparedness material include PPE, thinking that not only pandemic, but there is Ebola, there are cholera, and there are many other diseases that see our priorities shift. On the other hand, and I finish knowing that we have limited time, is that, as you say, learning from our experience, and as well making sure that our plan, once we have, are properly funded, because I think this is a recurring issue. Even organizations that have beautiful, developed, professionally developed plan, maybe bigger organization, then at the end, donors do not like to fund in advance. I am old enough to remember moment in which in the humanitarian we had regional hubs with material that was ready to be deployed. We don't have this anymore. So I think a local and coordinated response is key for this kind of emergency. I can speak another 3 hours, but and not including as well the training that we need to give. We are talking more and more about the localization of humanitarian aid. And I think we have to use this pandemic as an example of something that can happen in a different, magnitude, but it can happen quite often. And we have seen in the field happening, at least myself, on cholera, country where cholera is endemic, there is no preparedness, there is not adequate response. So I stop here, passing back to Ryan to introduce next panelists, and thank you so much.
Thank you, Dr. Dalla. No, that was a really, I think, a very nuanced answer. So I appreciate that, and also I think a good segue into my next question. And this question is for Ashley. Ashley, one of the issues highlighted in the report and in Donatella's answer just now is this challenge of coordination, and perhaps specifically between the maternal, newborn, reproductive health community and the outbreak response community. So I'm wondering if you could share some of your thoughts around some lessons that we can learn from this pandemic to improve on coordination for future waves or even for future outbreaks.
Thanks, Ryan. I'm coming to you today. I'm just going to take a moment just to give a little bit of background. Wearing my IAWG hat, and for people that don't know, the Interagency Working Group on Reproductive Health in Crises is an international coalition of organizations and individuals working to advance sexual reproductive health and rights in humanitarian crises. And they do that by developing global guidance. So for example, the MISP, which I'm sure is known to many of you, but maybe not everyone, the Minimum Initial Service Package for Reproductive Health, which is a set of priority interventions to be implemented in a humanitarian crisis, that is put out developed and put out by the IAWG. The IAWG also does advocacy to ensure sexual reproductive health is included in humanitarian emergencies. And also the IAWG works to help identify gaps and fill gaps when we see that sexual and reproductive health isn't being prioritized or there are needs that aren't being met. The IAWG helps to amplify that and bring resources, tools, and advocacy on behalf of that. So at the outset of the COVID-19 outbreak, I wanted to kind of touch on one thing Donatella said, which was, what we do with lessons learned. So for IAWG member organizations and individuals, there was a lot of sounding the alarm because there was real concern that sexual and reproductive health would be sidelined during the COVID-19 outbreak, based on the learning from previous public health emergencies, and most notably the 2014 Ebola outbreak in West Africa and subsequent Ebola outbreaks. And so there was a real need to kind of circle the wagons and make sure that we pulled together not only interested IAWG member organizations, but also individuals working at the front lines to ensure that we could be bringing attention to creating the right guidance and advocating to make sure that sexual and reproductive health would be included in all COVID-19 response activities. And what we found was, I think based on based on our experience, we found that a lot of the things that were challenges and problems in previous public health outbreaks were also real big issues in this particular outbreak. And just to bring attention to the specific example of coordination, so one of the things that the IAWG COVID-19 task force did was organize conversations with frontline implementers. So organizations really working at the intersection between humanitarian crisis, other crises, COVID-19 outbreak, and sexual and reproductive health and rights. And a lot of the things that come out in the READY report are things that we really were hearing early on, that there was a lot of conflicting guidance, that this was even more complicated by issues such as there being multiple emergencies going on at the same time. So a conflict on top of a public health emergency, on top of sort of underlying fragility of the government. And so a lot of that led to a lot of, as Alice described, tensions. And what was sort of left to the side was sexual and reproductive health. So we were seeing that, as described in the report, that staff were being deprioritized from sexual reproductive health onto COVID-19 response. And what we were really trying to do in the IAWG COVID-19 task force was really bring attention to the fact that implementers were really saying, we know how to adapt our programs to ensure that sexual and reproductive health can continue, and that the essential services can continue during COVID-19 if we have certain support, if we have the PPE, if we have the ability to reorient the facility, or if we're allowed to shift policies in such a way where we're allowed to do telemedicine or do remote counseling or do some of the other things that are described in the report. And I think that in terms of coordination, this is also brought out, I think, in also some of the things that Donatella was describing, is really making sure that we're starting from the point where we understand that the frontline implementers and the staff on the ground, they really already have those adaptations in mind, and that the coordination should start probably from listening to their experiences, versus the other way around in terms of kind of a top-down inundation of tools and guidance that everyone was kind of scrambling to put into place. So I'm going to stop there, but just to say, I feel like there's a lot we can learn from this experience. And I think the real responsibility is on us as public health leaders to make sure that we actually listen to the lessons and keep trying to advocate and push those forward, so that there isn't this tension between we're responding to an outbreak and we're providing essential life-saving services to women and children and newborns, that those essential services can be provided in and must be provided in a public health emergency and outbreak. And as mentioned, like, we just need to start now figuring out what are those processes and procedures to ensure that that happens from the beginning.
Yeah, no, thank you, Ashley. That's clear, and I think a good call to action, and also relates to the question that I have here for Shehu, thinking specifically about how we're designing global guidance for these frontline workers. So Shehu, I'm wondering if you could speak a little bit to how we can develop or adapt this global level guidance to better reach and be used more by frontline workers in the field or at the programmatic level.
Okay, thank you so much, Ryan, and everyone. I am Shehu Dasigid with a bit been responding to humanitarian emergency in very complex places like Maiduguri in Nigeria, and also currently in Sierra Leone, working on a Saving Life project. Of course, guidance, global level guidance are actually very important tools in in combating any form of outbreak or responding to any form of outbreak. But it all boils down to how it is being utilized, and that for us to be able to ensure that global level guidance is properly utilized, it has to go in a chain, right? In the sense that every member of every stakeholder, every actor have to make sure that we are on top of, we utilize that particular guidance to be able to provide responses. But in there are certain situations where you discover that the guidance are properly developed, but it's at some certain level, the chain is not continuous. Maybe, for instance, you have other actors like other INGO actors, where each individual organization have its own particular guidelines and which they use. And also the state actors also, it's possible the state actors also are not well familiar with this global level guidance. And also, even if they are familiar with it, it has not been disseminated down to the bottom level, like the state or the district level. So in this case, for us to ensure that this global level guidance are well utilized by the frontline field staff, it has to come, there should be some level of familiarization workshop or some high level familiarization exercise that should be carried out at each level, in the sense that that is going to bring all the nationals, both the government and non-governmental actors together to get themselves familiarized with these guidance, with these tools. And also that should also be disseminated down to the state and the district level. And also that should be some kind, and that should follow up by some kind of a rollout sessions to the frontline service providers for them to be able to make use of those tools appropriately. And we should not just stop at that. There should also be some kind of a supervisory monitoring committee that are going to monitor the compliance level of those guidelines from a different level, at both national level, at the district or the state level, and down to the field levels, which that should be properly, that the committee should properly ensure that those guidance notes are properly utilized in a more compliant way. And also, aside from that, also, we also need to identify some key indicators that will be used to measure our performance in terms of utilization of those guidance. So we need to agree on a certain key indicators that should be used. And also there should be some kind of a bottom-top feedback mechanism where should be put in place that should flow through the committee, that we should be able to get feedback directly from the field on the guidance note, but which should also be used to analyze, to provide some kind of a review on the global level guidance to see what is working well and what is not working well, what can we adjust, and what can we improve. So those are some of the key recommendations I have on this. And yeah, I think that's yeah, I'm good.
Thank you, Shehu. Yeah, no, those are really insightful, and I think speak really well to the coordination challenges that Ashley was speaking about as well. Thank you, all of you, for those remarks. I think we're going to turn to some of the questions from the audience now, as there are some great ones there in the chat box and in the Q&A. This first question comes to us from Catherine, and I think perhaps this is to Ashley and to Donatella. And this question is about the absence of maternal, newborn, and reproductive health systematically in preparedness plans. The question is there a reason for this? Why we're not seeing MNRH included in these plans? And are there any tools or resources that you can recommend for organizations to leverage to better include MNRH services in these plans? Perhaps first to Ashley and then Donatella to Anne.
So I think the reasons that these services are not prioritized in preparedness plans, I think speaks to just an overall general, I keep going back to saying sideline, but just kind of deprioritization or the sort of lack of recognition that these services are as life-saving in an emergency or crisis as food, water, shelter. And I think that's an ongoing kind of challenge with respect to coordinating and advocating and being really present and kind of pushing for sexual reproductive health, maternal newborn health services in any kind of humanitarian crisis. I think that, I think one of the things which I think will be really interesting as we're starting to kind of explore some of the lessons and data that's going to be emerging from this particular crisis is to look at places where they did invest in preparedness plans that included those services, and was their response stronger overall? And I think that is the kind of sort of data and advocacy that I think will help to sort of shift the dynamic and perhaps elevate maternal newborn health preparedness sort of into the idea that this is something that can strengthen overall response. And again, I think that's sort of a hypothesis, and I wonder if the READY initiative is also looking at this. But I think in terms of tools and resources, there are a number of really great tools and resources that you can find actually even on the IAWG website, iawg.net, which really speak to and provide case studies also for work with governments and even local community organizations to help them with preparedness plans that include preparedness to deliver these particular services. So I'll also see if Donatella wants to add anything.
Very comprehensive, Ashley, thanks. Just maybe a couple of things. I'm not here to advocate for gender inequality, but I think there is an analysis on gender inequality that we should take into consideration, being the whole sector a female issue and not a global issue, it seems so. So I think we have to look at this as a sector that needs special attention, even because it is, how would I say, underestimate or deprioritize because of some imbalance in gender consideration. The other hand is being an emergency health person. I have been doing this mistake myself many times, is that when there is an outbreak, everything stops and we only look at the disease, the person, and we forget to think about essential services. And women will continue to deliver, and children will need to be breastfed, and as well as antenatal and postnatal care with many other services that need. So disruption in services, it is because we are considering emergency phase and then the normal things. As we have seen, we have closed schools, which is a decision that are very important, have a huge impact, but we cannot close delivery room. We cannot stop kids be born. So I think we have to take into consideration the gender component, but as well as, and we learn a lot from Ebola, where everything about Ebola, and we have seen the impact on, for instance, massive reduction in vaccination coverage. And as well, during the COVID, mass reduction, I'm not talking about everywhere, but in a lot of locations on utilization of services. Something is about stigma, something is about fear, but a lot is because services were not properly adapted and delivered.
Yeah, thank you for that, Donatella and Ashley, both great answers. I'm going to move us along just because we are running out of time. This next question is for you, Alice, actually. And this participant wants to know if this consultation process that you undertook helped to understand the importance of having a cadre of community-based midwives to cater to the needs of community deliveries, especially when health facility delivery is not possible. Did you see that coming out in the consultations at all?
Yeah, definitely. And I think it brought home the reality that it's so difficult for women and girls to access facilities during outbreaks. And we saw this in other outbreaks such as Ebola in the DRC, and we see it again with COVID-19. So there is definitely a need to invest in more research to look at how we can better utilize TBAs, how we can better strengthen the link between traditional birth attendants and health facilities. I like the idea of community midwives, how to create, whether it's a separate cadre or a shift in the cadre during outbreaks, which needs to be thought about in the preparedness phases. But I think it's definitely something that came up pretty much in every single workshop that we held, that this is a need that we need to put in more research sources and to find out what works best and not. I might throw this also to Shehu, because being on the ground, he probably has seen the direct impact on facilities, services closing or being less accessible to populations. And I don't know if he's got anything to add on this.
Thank you very much, Alice. Of course, there's a lot of negative impact on the COVID-19 towards our service uptake, most especially in a situation where the community have negative perception towards the COVID, that they felt the main places where to get infected, it is through those health facilities. And there's a lot of myths going around feeling that, oh, the people that brought in the COVID are the health workers, and a lot of people that are getting infected are the health workers. So that myth was, it actually caused a lot of barrier for those beneficiaries accessing services. And also, we have also government restrictions on movement, where people are not allowed to move around because of the total lockdown, and that also that cause a lot of barrier for the beneficiaries accessing the services, because some of the beneficiaries have to take on a public transport to get to access services. And with that, we've seen a lot of reduction in service uptake. And also in some communities where you see government put in restrictions, but then they provide transportation access for their own government staff, but the non-governmental staff were not given opportunity to drive, because you need a clearance for you to be able to drive around. So that also provides some limitations to health providers to be able to access the facilities to be able to provide services. So those are some of the challenges we've seen so far. Thank you.
Yeah, thank you, Shehu. And that actually relates really well to this question that came in from the audience. And I'd like to perhaps ask you, and we can extend it to the rest of the panel. This person suggesting that perhaps one step in these preparedness plans would be ensuring that some of these human resources systems, job descriptions, partner terms of references, including these in your preparedness plans in advance. Do you have any thoughts on this? Would you recommend, do you see that as an important component of the preparedness plan? Or have you seen this done well in other areas?
Of course, Ryan, this is actually a major challenge, especially with the start of the COVID-19 outbreak, where there's a lot of modification there was a lot of service modification, where some of the less priority services in code we are called down, and then we focus on the priority service that with high priority, and with that there's a lot of shift in terms of role and responsibility, where especially for instance in terms of triage, where you discover that a facility that is understaffed doesn't have sufficient staff to work with, and you need to set up a triage center where every client that comes in needs to be triaged, and of course the question is that who are those staffs who are those clinical staff that are going to be there to be triaging those clients coming into the facility. So we've seen a situation where there's a shift of role, there's a role shift to even engaging some non-clinical staff for triaging, but of course it requires a lot of training and requires a lot of time, but then there's a lot of questions that came up that about job description, and also definition of roles and responsibility, and also roll out some of those descriptions to individuals. So which it's something that from the beginning, it really affect the flow of implementation. But if we will have some kind of a standardized job description, roles, and for each cadre in the case of an outbreak, I think it will be very useful. And also in terms of coordination, you know, we've had a situation where there's some kind of a dilemma to who should lead the outbreak, who should lead the coordination. Is it the government? Is it the non-governmental organization? Is it so it becomes a problem, and who should fund certain activities? But then with clear definition of roles and responsibility and clear job description, we'll be able to know who should be activated at when and where and how. So by the time we have those clear definition, I think it will really go a long way to help. Thank you. I hope I'm able to answer your question.
No, that was a great answer. Thank you so much, Shehu.
Okay.
It looks like we are just about out of time, so we're going to do just, I think, one more question, and then we'll go ahead and wrap up. Alice, this last question is to you, and this person wants to know if frontline workers were included in these interviews and consultations, since you mentioned they were underrepresented in the workshops themselves, and if there's a plan for findings to be shared at the implementation level.
Yeah, good, great question. So sadly, we only did workshops. So sadly, because were not included in the consultations. We relied on program managers, coordinators who are in the field, who have direct contact with these frontline workers to relay a lot of that information. But of course, that's never as good as actual face-to-face time. So that was, which is why it was included as a limitation of the study. In terms of sharing these findings with the implementation levels, this report will be shared with all the participants who took place in the workshops, so who are real stakeholders in these findings, with the hope that they will then disseminate at their level with their teams what the conclusions of this report. And then this report will be driven, I believe, by RHiE and IAWG through their work to try and push forward the recommendations and make sure that as many people know about it. And the recommendations are very broad and talk to a lot of different stakeholders in the MNRH sectors. So the more people know about it, the better.
Great, thank you, Alice. And a big thanks to all of our panelists, Donatella, Ashley, Shehu, thank you so much for joining us and lending your expertise for this hour. And of course, a big thank you to Alice for the presentation and for sharing these findings. Just a reminder to folks that the recording from this session will be shared out via email and be available on RHiE's website, rhie-initiative.org, where you can also find the paper that includes all these recommendations. Finally, big thanks to RHiE and to IAWG for making this session possible, and we do hope you all have a good rest of the day. Thank you very much.
Thank you.
Thank you.
Thanks.